Okay, so this is care of a nasogastric tube on suction. So we have our trolley here, and we have a pen light to check the patient's throat. We have tape to secure the nasogastric tube. We have alcohol swabs to clean the nose of the patient and clean the nasogastric tube as well. If there's any aspirate on the outside, we have saline to flush the tube. We have a tongue depressor to check the oral cavity of the patient. We have litmus paper to check the pH of the aspirate, and we have our catheter tip syringe. And we have a bluey to make sure that no aspirate goes on the patient. So now we're ready to begin. Alright, first we introduce ourselves to the patient. Hi Mr. Smith, how are you going today? That's good, my name's Angela and I'm going to be taking care of you today. And I just need to assess your nasogastric tube. Is that alright with you? And he says yes. So first of all we draw the curtains to ensure privacy of the patient. Like so. And we perform hand hygiene. But normally we would do this over a sink. So we perform hand hygiene to prevent the spread of pathogens that cause infection and could possibly harm the patient. So we do this for his protection. And yeah. So next we want to observe the Alright, so before we assess the nasogastric tube, we look at what type of tube this is. So this is a Salem sump tube. We know this because it has a blue pigtail. And this blue pigtail is used for air pressure. So we never inject fluid into this because it's used for air pressure, and when we put air into this later, as I will demonstrate, we do this to ensure that the tube isn't lodged in the stomach wall and that the tube is patent. So this is our Salem sump tube. Okay. So we can have two different nasogastric tubes. Yeah. Alright. So this can be either connected to drainage, a drainage bag, a free drainage bag, or a canister. It just depends on hospital policy and what the doctor wants. So right now this is connected to a free drainage bag, as you can see. And we're going to, first, before we check the patency of the tube, we're going to assess the nasal cavity, how much aspirate is draining into this bag. We want to assess the color and consistency and the odor of the bag, and we want to document this on a fluid balance chart. And when we assess the color, it should be colorless to bile green yellow, and this is normal, but any brown or coffee brown color should be reviewed by a medical officer because this could indicate gastrointestinal bleeding. So we've assessed how much has drained, the color, the consistency, and we've documented it, and now we're ready to assess the tube. So we want to perform nasal care first, so the glove up. So we've gloved up, as you can see. And we want to perform nasal care every 1 to 2 hours This is because the nasogastric tube in the nose can cause the breakdown of skin and it can cause inflammation, and we want to prevent that. We want to check for any redness or slough, or we want to check the skin color or if there's any inflammation. So firstly, we remove the tape very, very carefully because we don't want to dislodge the tube from the nose. Because if we dislodge the tube, then we'd have to reinsert the nasogastric tube in the patient, and this would cause him excess discomfort, which we don't want. So we've taken the tape off the nose. We'll put that in the bin. And now we are going to swab his nose with an alcohol swab, like so. I'm going to swab his nose to make sure it's clean. There we go. And there's no aspirate around the tube. There we go. So it's all clean now. And now we're going to replace the tape. So we cut it down the middle so that it goes around the tube, like so. Place it on his nose. How are you still feeling, Mr. Smith? And he's alright. He's not feeling any discomfort.
Ouch.
Mr. Smith is fine. There we go. And always be careful not to dislodge the tube. So we've assessed, we've performed nasal care on him, and now we're going to perform oral care by checking the cavity of the mouth with a pen light and a tongue depressor. So we want to check his oral cavity to make sure that the tube isn't coiled at the back of the throat, because this could impact on his ability to breathe, and because he's only breathing through his mouth, therefore it could affect him very, very badly. Yes, because so we're checking to see if the tube is coiled, and it's fine. We're also checking for any inflammation or redness, and there's none. So he's okay. Thank you, Mr. Smith. So now we've performed oral care, we've performed nasal care, and now we're ready to assess the patency of the tube. So firstly, we secure the tube to the patient's clothing to make sure it doesn't dislodge. And if the tube is on suction, we are going to disconnect it from the suction. And next we are going to inject 5 to 10 mils of air to ensure patency of the tube, and also to make sure that the tube isn't lodged against the wall of his stomach. So we've disconnected it, like so, and we're going to put a bluey on him. You alright, Mr. Smith? That's good. We dislodged it, we keep the tube, and now we're going to insert it into the air vent. Alright, so we inject 5 to 10 mils of air, like so, into the air vent. And like I said, this will ensure that the tube is not lodged against the wall of his stomach and therefore causing any blockages. So at the same time, while we're injecting the air, we're also listening for the sound of air being pushed into the stomach. This will be evident with a whooshing noise. So we listen with a stethoscope over the stomach, and when we push the air in, we're listening for the whooshing noise. So we can hear it, and we know that it's in the stomach. So we're going to re-secure the tube, like so. We're going to place it on our bluey. Now we are ready to flush the tube. Okay, so we get a new syringe, and we want to draw up about 5 to 10 mils, no, 10 to 20 mils, sorry, of normal saline. And we're gonna insert it into the clear tube. We never insert it into the blue tube, like I said before. And we're going to insert it into the clear tube to make sure there's no blockages or no aspirate in the tube. Aspirate. But first, before we do that, I'm going to aspirate. Alright, so I'm going to aspirate the stomach contents first in the clear tube. And we want to aspirate or pull back the syringe and drain about 30 to 50 mils of aspirate or stomach contents, and we're going to check the pH.
Yeah, we did neuro last year.
I was getting to that. We're checking the pH to confirm that the stomach is in the tube is in the stomach, and gastric contents. If it's in the stomach, gastric contents in the stomach will indicate a pH of less than 4. But as nurses, we should always review the patient's medication chart, because acid-inhibiting drugs can cause the aspirate to have a pH of about 4 to 6. So we always review the patient's medication chart before we assess the nasogastric tube. So we've got our aspirate, and we've got our litmus paper. So we take a piece off, like so. There we go. And we're going to just put a little bit on, like so. And normally this would give us a pH of less than 4, and it would indicate that the tube is intact in the stomach, which is what we want. So we get, so we've checked the pH, and also at the same time we've checked the color and consistency, and we've documented that on the patient's notes. And now we're ready to irrigate the tube. So we get a new syringe, like so. Normally I would have a new syringe, but we draw up about 10 to 20 mils of normal saline to flush the tube. We're going to flush it in this clear tube, not the blue tube. And we could also use water, sterile water, but saline is preferable because it would minimize the electrolyte loss from the patient's stomach. So we use saline, as so.
No blood. Get the still blood everywhere. Right, well that didn't work properly. Be careful. Because the head's actually
a second tube.
I actually just crashed mine. I was trying to do that.
Like so. So we inject about 20 mils of saline into the clear tube, like so.
Yeah. There's a little bit of blood.
And we do this to flush the line and and ensure patency. We do this to ensure patency and that there's no aspirate in the tube. So we've injected it and it's going in, as you can see, like so. I'm laughing. And then immediately after, we aspirate the fluid. And we should get about 20 mils, but if it's more or less, we document that on the fluid balance chart. So we've aspirated it, and we've documented it, and now we reconnect it back to suction if he's on a low suction, or we connect it back to the drainage bags. But before that, we will insert 5 to 10 more mils of air into the blue peg again. This is to ensure that the tube isn't lodged in against the wall of the stomach. So we insert that like so, and then we reconnect it like so, and we ask the patient how we're going. Are you right, Mr. Smith? And he's fine, he's not in any discomfort, and we are done. Deconnect it. And reconnect it back to the suction. Yeah.
I understand.
I said that before though. We reconnected it back to suction, and now we're done. I said that though.